Good afternoon. Welcome to the Philadelphia Regional Center for Children's Environmental Health PRCC-EH seminar. It is my great pleasure today to introduce Dr. Shan Sengupta to present at today's seminar. Dr. Sengupta is an attending neonatologist and assistant professor of pediatrics at CHOP. She received her medical training from All India Institute of Medical Science and MPH from Johns Hopkins Bloomberg School of Public Health. She completed pediatric residency at the University of Buffalo and completed a neonatal perinatal medicine fellowship at CHOP. Her research has a focus on mechanism of the circadian regulation of lung inflammation, injury, and repair regeneration. She also examines the effect of early life exposure on the development and function of pulmonary circadian networks. She was a recipient of the Fuchs OID Award for attending the Early Career Women Faculty Leadership Development Seminar organized by the Association of American Medical College and for the leadership training. Her research has received NHLBI funding as principal investigator in the KO8 and RO1 mechanisms. Today, she will give us some really good understanding of on the circadian regulation with the title of Hearing the Clocks Talk, Circadian Regulation on Lung Inflammation and Repair.
Thank you so much for this invitation and the kind introduction. I'm very happy to share some of the circadian work we have been doing in the area of lung injury, inflammation, and repair. I also realized that for early life exposures and environmental exposures in children, I don't think that I have a lot of, or any data for that matter, but I do think that it got me to thinking more about how the environment around us is, particularly in developing organs and systems like we have in children, how that's such a crucial window, and even otherwise, how there might be a lot more opportunities for interaction across circadian biology and environmental, toxicology and these kind of fields. I just wanted to give a quick outline about the definitions and concepts. Maybe it's redundant for some, but hopefully that's the sort of background that you would need to understand the rest of the data slides, and then I'll show some of the work. And specifically, I'm interested in sharing the work that we've done on early life exposure. It's a very specific kind of exposure that's relevant to only a subsection of children, but I think it's a great model to start to think about these things. And I have just 1 or 2 slides on the effect of environmental exposure on circadian clock, mainly in the more speculative region. And then I thought we could end with some broadly speculative questions. So circadian rhythms, from just by definition, is something that happens approximately every day, or happens with a period of approximately 24 hours. And these are oscillations that one can see in various behaviors, as well as physiological aspects of organisms in the living world, where you have a 24-hour period to those behaviors. So it recurs every 24 hours, and it has a regularity to it. And if you think about it, it really emerged, circadian rhythms really emerged with life itself, because these rhythms are in a way manifested or probably emerged with the rotation of the earth. So with the energy cycles that paralleled oxidative stress cycles as the very primitive organisms were evolving in a very relatively hostile environment. And so being able to prepare or anticipate the influx of oxidative stress or the dearth of energy and surplus of energy was huge. It gave them a survival advantage. And that is something that's conserved, therefore, not from the oldest living organisms like cyanobacteria all the way to the complex humans, right? And so the same kind of principles and same genetic circuitry sort of is conserved, and that gives the circadian clock, to my mind, a huge level of importance in organismal homeostasis, but it also makes the system very redundant. So there is a lot of checks and balances and safety features in there, so that if you knock out something, other parts of the clock will compensate, which makes it harder to study, but definitely a very elegant and beautiful way of understanding how living things interact with their environment. So in this field, we have, we started out with, and I think it's still fairly thought of as a very neurocentric thing. Sometimes people think about it as a fairly sleep and circadian rhythms can sometimes merge. And the thought at that, like, many years back was that everything started in the brain with the suprachiasmatic nucleus. And that in turn dictated the circadian rhythms of every other part of our body or a function. We now know that that's not entirely true, and that there are a large number of individual organ systems and cell types that have their own clock. And one way to think about it is that while the light resets or helps the suprachiasmatic nucleus maintain its maintain or give it the right kind of onset and offset, there are other factors that reset the clock for the other organs, which may or may not be then modifiable by light. And so it becomes a lot of concepts to explain, and therefore I think that using a metaphor in those cases helps. So circadian rhythms are intrinsically endogenous rhythms. So these are independent of anything that you are doing. So it's very similar to, say, a child swinging by herself. And if you imagine that space to be a completely inertia, like completely resistance or friction free, then that endogenous oscillatory behavior can be continued for a while, right? You can continue to have these self-sustained oscillations into eternity. And that swinging behavior, those oscillatory mechanisms are really your endogenous clock. So they are completely independent of everything else that is going on. So they would not be swayed by other factors, but they are not dependent on them, if that makes sense. Now imagine this girl is now getting this regular well-timed push from a friend. This friend in that case would be a Z-GABAer. So light, for example, in the circadian context is the most important Z-GABAer. So it is not as if the rhythms are dependent on light, but they are definitely swayed by it. And then over a period of time, if you keep exposing the organisms to this regular well-timed impulse, like Z-GABAer, like light, then you go through this process of adaptation to these imposed cues or entrainment. So light has entrained a lot of our behavior, so has food timing, and depending upon the organ system, there might be other Z-GABAers that are more relevant than light, but light does remain a very important and well-studied Z-GABAer overall. So now if you know all of these concepts and you know that it's not just the suprachiasmatic nucleus who's doing everything, then you can think of a slightly alternative version of circadian rhythms in living organisms. And that's more like an orchestra, right? So you have the suprachiasmatic nucleus, will serves as the conductor, but individual organ systems and cell types have their own endogenous clock or their own instrument, and they have the primary control over their instrument of choice. In this case, their endogenous clock is probably the most relevant to the functions that, say, the lung performs. The endogenous clock in the lung is the most relevant one, but the suprachiasmatic nucleus provides this overarching conductor-like function that helps all these different clocks to work together in a manner that's overall conducive to the homeostasis of the organism. And the reason why this is possible, that individual cells and organs can have their own cell intrinsic or cell autonomous clock, is because of the existence of the molecular circuitry of the circadian clock, which includes a large number of, or a small number of, I guess, depending on how you think about it, genes, or the core clock genes. These are all nuclear receptors, and they go through this transcription and translational feedback loops. The translation and transcription happens with a delay, so that there is one set of genes that's active during the day, another set that's active during the night, and they can bind to these promoter regions and either serve as a negative element that represses the transcription of a particular gene, or act as a positive element and enhance or induce the transcription of certain downstream targets. And through this phasic transcription translational feedback loops, you can have a phasic expression or oscillatory expansion of a large number of clock controlled downstream genes or the clock outputs. And if you have rhythmic expression of these genes, you can then imagine a situation where that translates into rhythmic expression of certain biological processes. Some of the better known ones are probably rhythms in heart rate, rhythms in blood pressure, but also many of our behaviors and various physiological as well as biochemical processes that do show a very clear circadian patterning. And the elucidation of this molecular circuitry in Drosophila is what was recognized in the 2017 Nobel Prize. And so what these individual genes therefore do manage to do is have the transcriptome at an organ or cellular level be under circadian control. Almost 50%, or 25–40% is probably conservative, of the transcriptome is under circadian control, and therefore by extension proteome and metabolome also oscillates. And the interesting thing is the circadian transcriptome is fairly customized. It's very tissue specific. So the pathways that are part of vital functions in any particular organ, those are the ones that would be under circadian control, say in the lung. If those pathways are not important in the liver, those will probably not be under circadian control in the liver. So there's a fair level of customization brought into the process. And what we have, and if you want to visualize this on what does it mean that the transcriptome is under circadian control, then I encourage you to look at this heat map with me. This is work from Gangru Yang when he was in Garrett Fitzgerald's group, and it's published a few years back. But this is 4-hourly collections of the liver in a wild type mouse. And you can see from tracing the highest expression along the heat map that there's a nice circadian rhythmicity to it. However, if you get the same kind of collection from the liver in a mouse where the clock is not active because it has been genetically ablated, then you lose that very nice patterning that you were seeing. And it seems doesn't matter when you are looking at it, everything is either low or high, but it's consistently so. And that I think is really powerful for me, because it means that a large number of these processes and things are not really fixed in time, but are oscillating. And so you'd heard about Z-Gevers a few seconds back. And so I just want to do a little bit of circadian terminology that you will see as you see the next few slides that are more data-driven. So ZT time or Z-Geber time refers to, it's a clock speak of how we refer to time. And because the light is the most prominent Z-Geber, particularly for the central clock, we start the clock essentially at 0 when the lights go on. So ZT0 is when the lights go on, and ZT12 is when the lights go off. And the corresponding times in darkness are referred to as CT. So CT0 and CT12 would be lights on and lights off if the corresponding times with the lights on and off, but in constant darkness. And so this essentially is the subjective dawn and subjective dusk. in our case. We are not going to use 0 and 12. We are going to use the time just before 0 as ZT23 as dawn and ZT11 as dusk. And we can go into discussion later on why those timings were chosen, but you'll see ZT23 and ZT11 appear in the following slides again. So when I started looking or thinking about circadian rhythms, and I'd already had some background in the lung, one of the questions that I wanted to ask is, how does the lung clock affect the outcomes that we think about more often with the lungs? And with lungs, particularly as we emerge from the pandemic, it's fair to think about lung infections and how the clock might be affecting lung infections. However, the lung is not a uniform entity, right? It has more than 40 different kinds of cell types. And so the lung clock really is an amalgamation of a large number of other clocks that are contained within these individual subcompartments. So you have the epithelium, whether it's the alveolar or the airway, you have mesenchymal cells, immune cells, endothelial cells, all of which have their own clock. And then you probably have rarer neuroendocrine and other kinds of cells and that have their clock mechanisms. So a part of my lab's work is understanding these mechanisms at the cellular and molecular level so that you can move towards building an entire blueprint of these mechanisms, all in an effort to see how these can then be leveraged or harnessed towards improving lung health. And the other part of the lab, which sort of is tied with these mechanistic bases, is understanding the behavior of these clocks under special host contexts or environmental contexts. So early life exposures or shift work, an aging host, or the environmental disruptions that one faces, say in an ICU or in a hospital. So these are the two kind of paradigms that we think about, but just in one slide itself, I hope I've conveyed to you that there are layers of regulation here. It's not as simple as just one clock, and individual circumstances probably affect these clocks in a differential manner. So how does one start asking questions about a system that's so complex? So fortunately, anything in biology that oscillates, that goes up and down, therefore you can assume that the response of the host will also not be a static since it's oscillating. And therefore one of the hallmarks of circadian regulation is, particularly in the case of lung infections, is that the host response will be dependent on the timing of insult. Probably applies best or is easier to test when the insult is discrete, would be harder to do for long, continuous, long-standing or chronic exposures. But because we had the ability to use a discrete infection to test this hypothesis, we designed this study in this manner. And this is a fairly common circadian experimental design where you say we took mice who are Black6 and infected them either at morning or dawn, ZT23, or at dusk, ZT11. The ZT11 part corresponds to the timing where lights are just about to go off. So it's the beginning of the active phase of mice. And in the dawn part corresponds to the part where the animal's about to go to their rest phase, because mice are nocturnal. And then you follow them out for 14 days. And what we found was that just by changing the time of day at which you are infecting, you can change the outcomes threefold. So mice infected at dawn had 3 times higher survival than mice infected at dusk. And you see a similar pattern in their weight loss trajectory as well as clinical scores, suggesting that this is definitely a very like a factor that determines both morbidity and short-term mortality. And so this does confirm that there's a diurnal effect, but we still don't know if it is circadian or not. So to do test that, we did the same experiment, but with mice wherein the clock had been disrupted by deletion of this core clock gene RBMOL1. And once you delete this and treat both the wild type and the knockout animals at dawn or dusk, we see a very similar response for the wild type animals, where animals infected at dawn had significantly better outcomes than animals infected at dusk. However, this time of day difference was lost and the severity was worse in the group there where the clock had been disrupted by global BMAL1 deletion. So the question really at this point is, why is this happening? Are we somehow more likely to clear out the virus if we get infected in the morning, or are our immune responses ineffective in the evening? And so to address this question, we first looked at the viral titers. We looked from 6 hours all the way to day 6, and we found that there was really no time of day effect on the viral replication process. And so given that the viral burden was comparable, we then looked at the host response, and just looking at one time point, say day 2, we saw that even though the viral titers were so comparable, the inflammatory cell output that you can see in the lung in the terms of bronchoalveolar lavage cell count was significantly higher in the group that was infected at dusk, or ZT11, and has poorer outcomes. So there is an exaggerated inflammatory phenotype here that's significantly more than the group that's infected at dawn and does better. When we looked at the histology, we saw a similar effect. This is day 6 histology, where the group infected at dawn also has some inflammation, but the group infected at dusk has significantly more inflammatory infiltrates around blood vessels, airways, throughout the alveoli. If you look at higher magnification, the epithelium also appears more necrotic in the group infected at dusk, and this is nicely objectified here. So in acute terms, there definitely seems an effect because you're starting at either dawn or dusk. But the question is that, does this persist? Or is this an acute effect that once you've gone through, say, 30 or 35 cycles of circadian rhythms, then it doesn't matter? Because why should it matter whether you started in morning or evening when you're looking at a time point that's many, many days later? And so we asked the same question on whether this is just a one-time acute effect, or is this something that affects lung repair and regeneration as well? And we did the same experiment where we infected mice at either dawn or dusk, but this time we recovered them out. We infected with a dose that was low enough to not cause significant mortality. And when we recovered them out to day 30, we found a very similar effect where the group infected at dawn, which had better outcomes in acute mortality and morbidity, also had much less immunopathology than the group infected at dusk. Physiologically, we appreciated this in the terms of difference in pulse oximetry, with the group doing poorly, having lower pulse ox values than the group infected at dawn. We found the same kind of effect if you knock out the core clock gene BMAL1, and where on day 30, you see a lot more immunopathology in the group without the clock, similar scoring, much lower pulse ox values than the group infected at morning. So ongoing work in our lab is going into the individual mechanisms of these behaviors, and we found that the type 2 clock, or the alveolar epithelial type 2 resident clock, is a main player in this immunopathology phenotype, as well as the lung repair phenotype. Then we've grown lung organoids to get into the story of repair and regeneration, particularly regeneration that's independent of inflammation. But I don't want to talk about that here. That hopefully is going to be out very soon. But I instead want to talk about a more recent project where we are looking at these circadian mechanisms, but in a more translational model, using sort of the ICU hospital environment disruptions associated with such an environment to model what it does to our circadian rhythms and whether it has impact on outcomes. So we have talked about influenza already, but one of the things that I want to convey in this part is that severe influenza, most of the influenza is probably mild and that barely gets diagnosed, or you're sick for a day or two and then you're up and about. But in the more severe cases, you do require hospitalization and also ICU care. And that is true for not just flu, but many other respiratory infections, both bacterial and viral. And once you enter the ICU, yes, you are getting life-sustaining therapy, but you are also signing up for a large number of disruptions that we have, that's become part of the process of how we practice. I'm a neonatologist and I attend in the neonatal ICU. So I know that there is a strong culture of considering these disruptions as part of care almost. So this is an attempt to understand whether some of these things should really be questioned again. And so I propose the ICU care as a model of environmental disruptions. Of course, we are doing life-sustaining and very important therapies, but one facet, for example, like there are many facets in which ICU probably provide a huge level of environmental disruptions. We are going to talk about only one aspect of it, and that is the lighting. And so the ICU environment, for anyone who's either been an attending or a patient in the ICU or has any kind of interaction, they'll know that there is really no rhyme or reason. It's fairly erratic. It changes from day to day. It changes from patient to patient. It changes from who the provider is. So it is particularly characterized by a fair amount of nighttime exposure. And therefore, one of the questions that we wanted to ask was, is there a window of vulnerability or opportunity based on whether you are a glass half full or half empty person for the outcomes in influenza infection? Is there, we are taking specifically the case of influenza infection, but I assume that would apply to other infections as well. And one of the ways that we wanted to check for this window of vulnerability is to use lighting and disrupted lighting or disrupted light cycling to mimic whether there is another window of opportunity for us to be more cognizant of what kind of exposures we are putting patients who enter ICU or hospitals to. So what we did for that was to use the very same model that we have earlier, where we either infect animals at dawn or at dusk. But this time, after infection, for the first 4 days, they remain in constant light-dark cycling like they have always. And the group infected at dusk remains so throughout the entire study. However, the group that's infected at dawn and historically supposed to do really well, that group we split up into two portions, one that remains in the 12-hour light dark cycling or the normal control arm, and the other arm goes into constant light. And we chose constant light because there is really no great way of mimicking the erratic lighting in ICUs and hospitals. So we thought of using something that would be as disruptive as possible. And so when we do this, we see that there is definitely a time of day difference between the dawn and dusk groups, all of which remained in the light dark cycling group. However, when you disrupt the lighting after day 4, this wasn't immediate, this was after 4 days of being in the light dark cycling, you lose that time of day benefit. And so even the group that looks or was supposed to have really great outcomes, you can disrupt those outcomes, you can perturb or make those outcomes worse by changing or disrupting the light cycling. And that's like, you know, we think about light here as lack of light cycling, but light pollution overall is fairly common in our modern lifestyle. So this probably has ramifications beyond what I'm showing here. And I wanted to show you the weight loss graph because it really nicely captures what we thought and what we ended up doing. So here, the groups are in ZT23 or the dawn group are fairly comparable, almost indistinguishable, but you move them on day 4 to constant light, and gradually the blue triangles move away from the black circles and become almost identical or overlapping with the red squares, which is the group that was infected at dusk and historically does poorly. So much to say that there is definitely a window that we have of being cognizant of what light dark cycling we are putting them through, or other ways that we are disrupting the environment, which, you know, is something that's affecting not just delirium or behavioral factors, but also affecting actually the lung-based outcomes. And we have more work defining what kind of aspects of the lung pathology are affected by going into constant light. But this is sort of my slide to pivot a little bit away from the mechanistic and animal model-based work and show you some of the work that we've done in the epidemiology space to try and understand what these animal mechanistic studies really mean for human health. Because one of the questions I used to get earlier a lot was, well, mice are nocturnal and they do well if they're infected in the morning. So what time should humans be infected? Honestly, if you had the choice, you'd probably be better off choosing not to get infected altogether, right? And the other aspect of that is that that'll never be something that we can control, getting infected and figuring out what time we exactly got infected. Yes, we could restrict access at particular times, but that's still a huge, big question mark on whether we would be able to control the timing of infection. So in that aspect, instead of focusing on that, I think take-home message of the work that we've shown mechanistically is that circadian disruption, not genetically driven, but driven by lifestyle choices that we are making, some by design, some inadvertently, are rampant. Those are ubiquitous. Everyone has done those. We have traveled extensively, or we've stayed up late. And so it's to understand circadian disruption from that context, I think people have looked a lot at shift work. The Nurses' Health Study, which is now going in through several cohorts of it, is a vast longitudinal study of looking at the effects of shift work. And the shift work here was relatively mild. It was 3 night shifts a month, which is not a whole, it's just not very high an ask. And so they found that there was increased risk of breast cancer, colorectal cancer, lung cancer, and ischemic stroke. And while the effects were modest, they did have a very incremental synergistic kind of effect if any other risk factor were present. So if you were only a shift work, you probably had a modest increase. But if you were a shift worker who also smoked, then the increase was much more amplified. So this is some of the work that's already done, and this is building up on a vast amount of work that's ongoing. These are older references, but there are many more now. And then this is work that we have done where we looked at the UK Biobank as a way of getting to ask these circadian disruption related question at a much large scale longitudinal database. So for those of who are not familiar with the UK Biobank, it's a large scale biomedical database, has over 500,000 adult participants, and provides a very rich source of data for following longitudinal studies and trajectories. And for this particular studies, we had over 100,000 adult participants, and the data had been collected from them for 1 or 2 weeks from hand-worn devices, much like Fitbit or Apple Watches, right? And so that had already been pre-validated for evaluation for circadian rhythms. And the outcomes that we were interested in was disease conditions, mainly infections. So when we looked at that, we found that influenza, pneumonia, and acute lower respiratory tract infections were the highest likelihood or associations, or the strongest associations with poor rhythms with need for hospitalization. In this study, however, we did not really differentiate whether the poor circadian rhythmicity came before or after the influenza diagnosis. So you can see how this may not be an association that's causal. In any case, proving associations that are causal is hard in these large epidemiological database, but we thought that we could improve on this study by trying a similar study, but this time we focused only on patients in whom we had the actigraphy data or the circadian data prior to the diagnosis of pneumonia or flu. And we ended up with over 80,000 participants who had the circadian data set that we needed. And then these patients were followed out, or participants were followed out, of which over 3,000 patients required admission for an infection, either flu or otherwise, but that affected lower respiratory tract. And so when you take these circadian measures, which we will refer to as relative amplitude or RA scores, and divide it into quintiles and plot it against the risk of hospitalization, you find not only a robust association between having poor circadian rhythms. The first quintile with the poorest circadian rhythms has the highest risk of hospitalization, and the fifth quintile with the lowest or the most robust circadian rhythm has the lowest risk of hospital admission. But what is also very nice is to see a very clear dose-response relationship, which definitely makes a strong case for causal relationship between these two factors. And this was adjusted for every kind of host-related factor that one can possibly imagine. And so we think that this is a very robust association. We saw a very similar pattern with risk of death within the first 30 days of discharge across the strength of circadian rhythms, again reinforcing the fact that our mechanistic work had a fairly strong translational relevance to it. And so from this part of the study, I think, or I hope I have convinced you that circadian rhythms do regulate host response and outcomes in influenza infection. Genetic disruption of the clock worsens those outcomes. And this effect is persistent. It's not one and done. It's something that you can see even later and should functionally be relevant. And then we have human epidemiological studies that reinforce the fact by having not only risk of hospitalization, but also a 30-day mortality post-discharge that's worsened or worse with poorer circadian rhythms. So for the next part of the talk, we'll take a little bit of a different approach and talk about the lung clock, but this time in a different special context of early life exposure, because I know that the perinatal group has a lot of interest in looking at environmental exposures. And so we'll use, however, that same concept of hallmark of circadian regulation being a difference in host immunology. And because early life is a time where there is also another very important clock that's relevant, and that's the developmental clock. And so it's essentially a blending of the two clocks, right? The developmental and the circadian clock, and how do they interact with each other, and what happens if you disrupt the developmental processes? Do you affect the circadian clock, and the consequences of it? So I get to test that in a special circumstance, because that's something that I clinically experience on a daily basis, and that's the case of prematurity and modern medical care. As some of you probably know, the vast majority of healthcare expenditure and morbidity that patients under 5 experience are driven by prematurity, even though the total number of premature babies is not very large, but the group that drives the healthcare expenditure is all often related to prematurity. So it's not only a one-time thing, but it's something that affects their entire lifetime of health and physiology. And they are born unequipped to handle the ex utero environment, which requires us to do more and more and offer more medical therapies, most of which put them through some very non-physiological conditions. And the prime example of that is hyperoxia, because the lungs come out in a much earlier developmental stage, and they are hypoxic a lot, and therefore you have to give supplemental oxygen. But supplemental oxygen itself is such a non-physiological concept that the body is really not used to or equipped to handle more than 21% oxygen levels. And that causes this chronic lung disease of prematurity, which has long-lasting effects on health, because they continue to have asthma, and severity of infections from respiratory infections is much worse, as well as COPD. And the first cohort of very premature babies are only now becoming mid to late adults. So there's, I imagine with our improving rates of survival, you'll see a growing number of ex-premature, but now adults who have a vast number of these respiratory morbidities. So this is what I was referring to earlier. The babies that we are seeing prematurely are born around 26-ish weeks. They are in the saccular phase of development, and that is when we are exposing them a lot to these non-physiological effects, whether it's hyperoxia or it's trauma from the ventilator management, etc. And so work in this space had been done now by Mike O'Reilly and Sharon McGrath-Morrow, who's now on campus, where exposure to early life hyperoxia made mice, these are mice, these are not humans, more susceptible to influenza infection. So these are adult mice who were infected with influenza, but if you were exposed to hyperoxia as a neonate, you had a much higher likelihood of dying than if you had been in room air and not exposed to these non-physiological circumstances. So one of the theories that we had was that what if neonatal hyperoxia, which we know causes disruption of lung development, results in bronchopulmonary dysplasia or chronic lung disease of prematurity, and is associated with these lifelong conditions of asthma, COPD, and respiratory infection exacerbations. But all of these in diseases themselves have a fairly circadian phenotype to them. And so what if one of the things that was resulting in from or causing these lifelong comorbidities was not just mediated by a disrupted lung failing to develop well, but also by dysregulated circadian networks, because presumably when the lungs developing at the same time, the circadian networks are also getting consolidated. And to do this work, this was work that was done by Yasmin Isa in my group a few years back. We took mice that were less than 12 hours old, or pups, and exposed them to hyperoxia or room air. And once they had been in hyperoxia or room air for 5 days, they were allowed to recover in room air, irrespective of whether they were in the hyperoxia or room air group originally, and then recovered out to adulthood, at which point they were divided into this dawn or dusk group and infected with flu. Just at this point, before the infection itself, when you look at the lungs, this is using a reporter for circadian gene expression. And these are lung explants that show these lovely oscillations if you were a lung that was only kept in room air. However, if you take a lung that had been exposed to hyperoxia, these rhythms are significantly dampened. And you can see these kinds of effects in the quantification of this data. And so when we looked at the outcomes of animals who had been maintained in room air all through, they had the time of day difference quite nicely noted, with the group at dawn doing better than the group at dusk. However, if you include the animals wherein the adults had been exposed to hyperoxia as neonates only for 5 days, very early in life, then you lost the time of day protection, and you also had severity that was comparable to the evening group. This was not just hyperoxia does bad things and the lungs are affected, so of course the outcomes would be worse. This is very specific to this developmental window, because if you did the same kind of experiment with adult mice, where you expose the adult mice to oxygen and then allow them to recover for a few days and then put them through infection either at morning or evening, you do maintain the time of day difference, but you cannot do that if you were exposed as a neonate, suggesting that there is the developmental window at which these environmental exposures or toxic exposures are being sustained is very critical. And so in thinking about this, I went back and tried to see if, like, hyperoxia in premature neonates, that's a very special circumstance and a very special case indeed. But there are more exposures like air pollution, light pollution. I think I've alluded to the light pollution a little while back. But I was looking through this and I found that even as this is an area of active interest, because there is studies and grants that are funded. This is from NIH Reporter this morning that look at air pollution, circadian disruption, and cardiometabolic disease. The abstract there says that they have work on PM 2.5 and the effects and how that might be mediated by circadian rhythms. I think that work is still underway because the papers are not yet out, but I was intrigued by how similar some of these things were with the things that are priority at the center here. And so I think that that itself speaks a lot to the possibilities of interfacing with environmental exposures and circadian rhythms, because circadian rhythms were designed to do just this, to be able to deal with environmental exposures that occur in a anticipatory manner or in a predictable manner. It does get a little more challenging because some of these exposures are more chronic. So one has to think really through on how to design studies to tease these aspects apart. But that makes it quite interesting to think about these kind of studies. So this is really the final conclusion slide, where hopefully I've shown you that early life exposures can disrupt circadian rhythms. And this is a unique developmental window because this same exposure at a different time of life would not have a similar disruptive effect on circadian rhythms. And this is probably one of the reasons why many of these early life exposures have such life course effects. Because circadian rhythms also have such different aspects of physiology that are controlled and regulated by circadian rhythms. And so hopefully understanding other environmental toxins and exposures, like hopefully I've shown you a template where we can probably do this with different other exposures and explore those possibilities. And so at this point, I would like you to indulge me for a few more seconds to think about the broader speculations for circadian rhythms. This is work by John Hoganish, who's up at Cincinnati, but used to be at Penn some time back. And he did this study looking at different drug targets and how these drug targets oscillate across time of day. And so these targets that we are hoping to change by giving a particular pharmacological agent is not the same, or they are not being metabolized at the same rate. So they should also not be effective if you gave them at the wrong time of day. And it has all the common drugs. These are the top 100 drugs that are commonly used. And we can see beautifully that many of the pathways that are involved either in the metabolism of the drug or in the actual effect of the drug are all under circadian control. And the broader speculations from this work, therefore, are not only trying to understand how different circadian drug circadian gene and their products could be tweaked to benefit the host, but also timing existing therapies, existing vaccinations to match up with the host circadian rhythm in a manner that it enhances efficacy without necessarily making side effects worse. But it also involves a broader discussion about how rampant circadian disruption is and whether it's really identified as a unique risk factor, just like, say, obesity is, on how circadian desynchrony can be an independent risk factor in causing a multitude of conditions. And the way we practice medicine in ICUs and the way we interpret data, irrespective of the time of day, also makes it kind of challenging to understand it if the biology were really that dynamic. I think with that, I would like to end. I'm going to shamelessly put in a plug saying that we are hiring, and if you have any questions, please feel free to reach out. If some of you are researchers and are interested in particular pathways, I also want to draw your attention to this really nice resource from John Hoganish's group, where you can plug in your gene and tissue of interest and really look at whether it is or not oscillating in your tissue of interest. And so it's a nice resource to have. These are all the people who did the work and who helped me along the way, mentors and collaborators and funding sources. The early life exposure work was done by Yasmin, and the ICU, mimicking ICU with constant light, is a group effort by all the people here, Madi, Alicia, Laura, and Ollie. And with that, I will stop and be happy to take any questions.
Thank you so much. This is really exciting.